Welcome to the Deep Dive, the place where we turn massive amounts of research into the most essential knowledge you need, fast.
Hi there. Today we're really getting into something huge: pain management. It's incredibly complex, affects everyone, and there's been what our sources call a major revolution in understanding it.
Yeah, a real shift away from those older, simpler mechanical ideas about pain.
Exactly. We're looking at a professional handbook, really comprehensive stuff, chapter by chapter.
So our mission today, give you that shortcut through the latest thinking. We'll cover the theory, how we even perceive pain, then look at specific clinical situations, like acute pain versus chronic conditions like arthritis.
And importantly, the modern ways we treat it, it's all about multimodal strategies now.
Right. So if you want to get up to speed on why pain management is so much more than just popping a pill, stick around. This is the deep dive for you. Okay, let's kick off with where this revolution really started. It meant dismantling a way of thinking that was, well, pretty dominant for a long time. Let's call it the old guard or stream one, the purely mechanistic view.
Yeah, that traditional idea was very linear, almost like flipping a switch. You get injured, receptors fire, messages shoot straight up the spinal cord, and the brain just sort of registers it, passively perceives the sensation.
Like a simple circuit board almost. And the core assumption baked into that
Was that pain had to have a direct proportional physical cause.
Yeah.
An injury you could see, an infection, some disease process, measurable stuff.
Right. If you couldn't point to the physical damage, the pain wasn't legitimate.
Exactly. And that's where things went wrong for so many patients for so long. If the physical proof wasn't there, or maybe the pain stuck around long after you'd expect the tissue to heal.
What then?
Well, the medical framework didn't really have a good explanation, so often the pain was put down to psychological problems, anxiety.
Or even worse, suggesting the patient was making it up, malingering.
Which, had devastating consequences for people genuinely suffering. It highlights why this whole theoretical rethink was so crucial.
So the revolution flipped that script. It started by saying the brain isn't just a passive receiver at the end of the line.
No, not at all. It's the central player. It's active. It's dominant. It shapes, integrates, and ultimately, you could say it creates the experience of pain.
It's not just the receiver. It's the operating system running the whole show.
That's a great analogy. And this led to concepts like the body self neuromatrix. Think of the old model like a basic doorbell, push the button, bell rings. Simple.
Okay.
The neuromatrix is more like a sophisticated home security system. It doesn't just get the signal from one sensor. It pulls in data from everywhere, maybe the camera feed, the temperature outside, past break-in attempts in the area, even how you're feeling right now.
So it integrates everything.
Precisely. And the output, the alarm, or in this case, the pain, is the result of this massive interconnected network spread across the brain. It's not just one spot lighting up.
And the amazing thing is, this isn't just theory anymore. We have the technology now.
Right. PT scans, fMRI. These imaging techniques let us see it happening. We can actually map pain-related activity in someone's brain while they're experiencing pain.
You can see it correlating with what the patient is reporting subjectively.
Yeah, you see activity across multiple areas at once, not just the somatosensory cortex, the bit that tells you where it hurts, but also the limbic structures, which handle the emotional side, the fear, the misery, the suffering that comes with pain.
And other areas, too.
Oh, yes. The frontal cortex is involved. That's your thinking, your interpretation, your expectations about the pain. And the posterior parietal cortex, which integrates sensory information and your sense of your own body.
And we know these areas have distinct roles because, as the sources mention, damage to specific parts can selectively knock out aspects of the pain experience.
Exactly. Someone might have a lesion, say, in a part of the frontal lobe. They might still report feeling the physical sensation. Yes, I feel something there. But they lose the unpleasantness, the emotional suffering that usually goes with it. The effective part is gone.
Wow. That really proves it's not just one simple signal.
It proves the complexity. So, to sum it up, that old Stream 1 thinking failed because it was purely bottom-up. Receptor signal travels to the brain, end of story. It totally ignored the subjective experience.
Or as the neuromatrix approach takes that sensory input
and immediately weaves it together with emotion, memory, what you expect to feel, how you think about it. The pain you feel is fundamentally a perception constructed by your brain based on everything going on with you.
Okay, so that's the big picture theory. Let's bring it down to the clinic now and talk about acute pain, the kind usually linked directly to some kind of tissue damage or injury. Where does it typically come from?
Sources break it down into three main origins. Cutaneous, so the skin.
Right.
Deep somatic structures like Muscles, bones, tendons, joints, and visceral structures, meaning your internal organs.
And knowing the source matters, especially when visceral pain, right? It behaves differently.
Absolutely. The key distinguishing feature of visceral pain compared to, say, skin or muscle pain is how vague the localization is. The patient often can't point to one specific spot.
Why is that?
It comes down to referred pain. Basically, the nerve signals from the internal organ converge onto the same neurons in the spinal cord that are also receiving signals from a particular area of skin or muscle.
Ah, so the wires get crossed, in a sense.
Kind of. The brain is much better at pinpointing signals from the body surface, so it gets confused and misinterprets the signal from the organ as coming from that related surface area.
The classic example they always use is appendicitis, isn't it?
Yeah.
Can you walk us through how that demonstrates referred pain?
Sure. When the appendix first gets inflamed, the pain signals travel via visceral nerves to the spinal cord segments around T10.
Okay.
Now, the T10 dermatome, the patch of skin linked to that spinal level, is around the belly button area. So initially, the patient feels this vague, poorly localized pain right in the center of their abdomen. That's the referred pain.
But it doesn't stay there.
No. As the inflammation gets worse, it spreads and starts irritating the parietal peritoneum, the lining of the abdominal cavity near the appendix. Now, that structure is somatic. It has precise nerve endings.
So the pain changes character.
Dramatically. It becomes sharp, intense, and very clearly localized to the right lower abdomen, right over the appendix. That shift from vague central pain to localized sharp pain is the textbook sign.
Makes sense. Understanding those pathways is key. Now let's talk about the danger zone. What happens if acute pain isn't treated properly? It's not just about comfort, is it?
Far from it. Unrelieved acute pain is biologically dangerous. It kicks off these nasty feedback loops, these vicious cycles, as the sources call them.
How so?
Well, the constant barrage of pain signals makes the peripheral nerve endings themselves more sensitive. But crucially, it also triggers changes in the spinal cord, that central sensitization we talked about. The system ramps up.
And psychologically?
That plays a huge role, too. Constant pain leads to anxiety, fear, inability to sleep. And all of those things actually lower your pain threshold, making the pain feel even worse. So the cycle just feeds itself.
And this is where the line starts to blur between acute pain, which should resolve, and chronic pain, which can become permanent. Is there a critical window?
The sources suggest it's shorter than you might think. If significant acute pain, especially after major surgery or trauma, hangs around beyond, say, 10 days, certainly by 2 or 3 weeks, it starts to take on chronic characteristics. You see those emotional and cognitive changes creeping in: anger, frustration, depression, hopelessness. The whole picture changes, and it becomes much harder to treat effectively down the line.
Which implies that modern acute pain services have a bigger role than just handing out painkillers when someone rings the buzzer.
Absolutely. It's fundamentally a preventative role. A key job is to identify those patients who are at higher risk of developing chronic pain within those first critical weeks.
How do they do that?
It requires looking beyond just the injury, assessing psychological factors, maybe social factors, looking for early signs of that central sensitization before it gets locked in.
And this need for effective early treatment leads directly to the standard of care now: multimodal analgesia, sometimes called balanced analgesia.
Right. The evidence for combining different types of pain relief is overwhelming.
That's the basic principle.
Attack the pain from multiple angles at once. Use a combination of drugs, maybe an NSAID like ibuprofen, paracetamol, perhaps a local anesthetic block. And yes, opioids often using different delivery routes too, like oral plus IV plus a regional block.
And the big advantage is
synergy. You get much better pain relief overall, but because you're using lower doses of each individual drug type, you dramatically reduce the risk and severity of side effects compared to just relying on, say, high-dose opioids alone.
Can you give a concrete example, say after major surgery where opioid side effects are a real problem?
Okay, think about major bowel surgery. Opioids are great for the immediate severe pain, but they almost always cause the gut to slow down or stop working. That's gastrointestinal stasis.
Which delays recovery, right. Can't eat, can't go home.
Exactly. So a multimodal approach might involve using an epidural catheter, delivering a mix of a local anesthetic and a very low dose of opioid directly to the spinal nerves.
Okay.
Then you supplement that with regular doses of non-opioid drugs systemically, maybe IV paracetamol, maybe an NSAID like ketorolac. The result: excellent pain control, but with a much lower total opioid dose, meaning the gut starts working again much faster. Patients recover quicker, go home sooner. It's just smarter pain management.
All right, let's shift focus now to some really common pain problems, musculoskeletal and connective tissue issues, starting with a huge one. Osteoarthritis, OA, knee pain from OA is incredibly prevalent.
Yeah, UK data suggests around a quarter of adults between 40 and 79 have knee pain. But the really fascinating, almost counterintuitive thing the sources highlight is what they call the X-ray disconnect.
Okay, what's that about? It sounds like it challenges how we traditionally diagnose OA.
It absolutely does. The old thinking, again, that stream one mechanistic view, was bad-looking X-ray equals bad pain. More joint damage means more pain.
Seems logical on the surface.
But the data just doesn't bear that out strongly. There's only a weak statistical link between how bad someone's knee X-ray looks, the structural damage, and how much pain they actually report.
Weak. How weak?
Well, get this. Studies show that somewhere between 7 and 14% of people with perfectly normal knee X-rays report having knee pain.
Wow, okay. Normal X-ray, but still pain.
And the flip side is even more striking. Up to 60%, 60, of people who have clear, unequivocal signs of severe OA on their X-rays. Bone spurs, cartilage gone, the works, report having no pain at all.
That's really something. It completely undermines the idea that pain is just about wear and tear.
It forces us to realize OA pain is way more complicated than just bones grinding together. Yes, the structural change is part of it, but it's interacting with inflammation at the joint level, changes in how the nerves are signaling that peripheral and central sensitization again, and also huge subjective differences based on mood, fear of movement, cultural factors, gender. The sources are really clear. Knee pain and what the X-ray shows should almost be considered separate issues.
So if the X-ray isn't the main story to the pain, how does that change how we manage OA?
Well, since OA, especially in the knee, has a strong biomechanical component, you have to address that. Weight loss is huge. If the person is overweight, less load on the joint.
Makes sense.
Strengthening the muscles around the joint, particularly the quadriceps, is also key for stability. Then for managing the symptoms day to day, topical treatments are great.
Like gels or creams.
Exactly. Topical NSAIDs or capsaicin cream, they're safe, they can be effective, and importantly, they give the patient a sense of control, something they can apply themselves when they need it.
What about steroid injections directly into the joint? Those are pretty common.
They are, and the evidence shows they definitely work better than placebo for reducing pain and inflammation, but the catch is, in controlled trials, that significant benefit often only lasts about 4 weeks.
Only 4 weeks. But anecdotally, don't doctors see longer responses sometimes?
They do, and that's the puzzle. Clinically, you definitely see patients who say they get relief for months, maybe up to 6 months. Why the discrepancy? We don't fully know. It might be down to differences in individual patients' levels of inflammation or sensitization, or maybe specific structural factors we haven't identified yet. Predicting who will be a long-term responder is still tricky.
Okay, let's switch to another major condition. Rheumatoid arthritis, RA. This is different from OA, right? It's systemic.
Very different. RA isn't wear and tear. It's a complex autoimmune disorder where the body's own immune system attacks the joints and sometimes other organs. It involves genetics, environmental triggers. We still don't know the exact cause.
And the pain pattern changes over time.
Dramatically. Early on, it's typically inflammation, pain, and swelling in the small joints of the hands and feet. The MCP and PIP joints in the fingers are classic spots. But in late-stage RA, after years of inflammation, the problem shifts to joint destruction, deformity, and significant loss of function.
And the treatment approach has really evolved here too, hasn't it?
Massively. Decades ago, the focus was mainly on NSAIDs to manage the pain and stiffness.
Just symptom control.
Right. But we now know NSAIDs do nothing to stop the underlying disease process or prevent the joints from being destroyed over time. So the standard of care now is early, aggressive treatment with disease-modifying anti-rheumatic drugs, DMARDs, and newer biologic agents.
To actually target the immune system itself.
Exactly. The goal is to slow down or halt the disease progression, not just mask the symptoms. It's a fundamental shift in strategy.
Beyond the joints, are there other complications like nerve problems in RA?
Yes, definitely. Nerve entrapments are common because the swelling and inflammation in the joints can physically compress nearby nerves.
Like carpal tunnel.
Carpal tunnel syndrome in the wrist is a prime example. Tarsal tunnel syndrome in the ankle is another. We also see more widespread peripheral neuropathies, sometimes a severe type linked to inflammation of blood vessels called vasculitis, and more often a milder sensory neuropathy.
And treatment for the entrapments.
Usually requires surgery to decompress the nerve and relieve the pressure.
Okay, finally in this section, let's touch on muscle pain itself, myalgia. The sources make a distinction based on timing.
Right. Two main types. First, there's immediate ischemic pain. This happens during intense exercise when the muscle isn't getting enough blood flow, like if you hold a heavy weight for too long, or the leg pain people get with peripheral artery disease when walking intermittent claudication.
And it goes away quickly.
Almost instantly when you stop the activity and blood flow returns. Then there's delayed onset muscle soreness, or DOMS. This is the one most people know from overdoing it at the gym.
Yeah, the pain that hits you a day or two later.
Exactly. It doesn't start for hours after the exercise, usually peaks around 24-48 hours, and can last for days. Often follows eccentric exercise, like running downhill.
Now, back to that immediate ischemic pain, I found the bit about lactic acid really interesting. We always blame lactic acid, don't we?
We do, but it turns out that's likely wrong, or at least not the main story. The key evidence comes from people with a rare genetic condition called McArdle syndrome. They physically cannot produce lactic acid during exercise.
Okay, so they shouldn't get ischemic pain.
You'd think, but actually they experience incredibly severe ischemic pain and muscle cramps. So if lack of lactic acid causes worse pain, lactic acid itself can't be the primary cause of the pain.
So what is causing it then?
The thinking now focuses on other metabolic byproducts that build up when blood flow is restricted. Potassium ions leaking out of muscle cells and adenosine are two prime suspects currently getting a lot of attention.
Fascinating. So when someone comes in complaining of muscle pain, myalgia, how do they typically describe it? What words do they use?
It's often quite vague. They'll talk about stiffness, soreness, aching, sometimes spasms. Stiffness usually means it's uncomfortable or harder to move, especially after rest. Clinicians also look for trigger points.
Ah, those knots you can feel sometimes.
Exactly. Those specific hyperirritable spots in a tight band of muscle made famous by Travel and Simons. Pressing on a trigger point can be exquisitely tender and often refers pain to other areas too.
But diagnosing myalgia isn't always straightforward, is it? Sometimes people have widespread muscle pain, but tests find nothing.
That's a huge challenge. There's a large group of patients who report significant myalgia, go through exhaustive tests, blood work, imaging, sometimes even muscle biopsies, and everything comes back normal.
So what do?
You have to use some rational criteria to filter things. Basic tests like ESR, which measures inflammation, and CK, which indicates muscle breakdown, can help pick up definite organic problems like polymyositis, inflammatory muscle disease, or muscle damage from alcohol abuse.
But for the rest, where the tests are normal,
it suggests we're still missing something. Maybe there are subtle neurogenic issues or problems with muscle metabolism that our current tests just aren't sensitive enough to detect. It remains a difficult area.
Okay, let's move into some specific regional pain syndromes, starting with heart cardiovascular pain. How do we tell the difference between stable angina and a heart attack, a myocardial infarction?
Generally, angina pain is deep, but usually less intense and shorter lasting than infarction pain. And crucially, angina typically doesn't come with that overwhelming sense of doom, nausea, or vomiting that often accompanies a heart attack.
Is there anything else?
One subtle sign is that patients often have deep muscular tenderness in the chest, shoulder, or arm areas related to the heart's nerve supply, and this tenderness can be present even when they aren't actively having pain.
Now, here's another challenge to the simple mechanistic view. The sources say the link between lack of blood flow ischemia and cardiac pain isn't straightforward.
No, it's described as neither strong nor unequivocal. It's not a guaranteed one-to-one relationship. You can have cardiac pain without clear evidence of ischemia on tests.
And the opposite is also true.
Very much so. Silent ischemia, where the heart muscle isn't getting enough oxygen, but the person feels no pain at all, is incredibly common, especially in people with diabetes.
So what does that imply about the pain mechanism?
It suggests it's more complex than just oxygen deprivation triggering pain nerves. There might be other factors involved, maybe changes in the sensory nerves supplying the heart itself, a kind of cardiac neuropathy, perhaps.
Interesting. Now, if we look at blocked arteries in the legs instead of the heart, we see a parallel condition, intermittent claudication.
Right. That's pain, aching, cramping, or sometimes numbness, specifically in the leg muscles, usually the calves that comes on reliably during exercise like walking, and is just as reliably relieved by stopping and resting for a few minutes.
And like angina, the key measure is how much activity triggers it.
Exactly. The free interval, how far they can walk before the pain starts, is the crucial indicator of severity. If that distance is getting shorter over time, it means the blockage in the leg arteries is getting worse.
Okay, moving up to the head and face or a facial pain. Let's start with teeth. because dental pain follows a very clear progression.
It really does. It's a great example of how inflammation evolves. It usually starts with decay, carries getting through the enamel into the dentine layer.
And the first sign is?
Sensitivity. The tooth becomes sensitive to hot, cold, or sweet things. The pain is sharp but brief, only when stimulated.
Then it gets worse.
If the decay reaches the pulp, the living tissue inside the tooth with the nerve, you get pulpitis inflammation of the pulp. Now the pain changes. It becomes more intense, throbbing, often spontaneous, starting for no reason, and it can linger after the stimulus is gone.
In the final stage, what's the key diagnostic shift?
When the infection and inflammation spread out beyond the tooth root tip into the surrounding bone, you get periapical periodontitis. The pain character changes again. It's now a more constant, dull, boring ache. The tooth is very tender to bite on or tap.
But the sensitivity changes too.
Critically, yes. At this stage, the tooth is often no longer sensitive to temperature changes. Why? Because the nerve inside the pulp is usually dead or dying by this point. That loss of temperature sensitivity is a key sign the infection has progressed beyond the pulp itself.
Makes sense. Now, let's tackle trigeminal neuralgia, TN, often described as one of the worst pains known. What are its hallmarks?
It's very specific. Sudden, usually unilateral, one side of the face, severe, sharp, stabbing, or electric shock-like pain that lasts only seconds to maybe a minute or two, but comes in recurring bursts, paroxysms.
And it follows the nerve pathway.
Strictly confined to the distribution of one or more branches of the trigeminal nerve, the main sensory nerve for the face. And a really defining feature is the presence of a trigger zone, meaning the pain can be set off by completely non-painful stimuli applied to a specific small area on the face or sometimes inside the mouth, things like light touch, washing the face, brushing teeth, shaving, even a cool breeze. Between attacks, the person is usually completely pain-free.
Given how specific that sounds, why do the sources say managing PN is still controversial?
Several reasons. It's relatively rare, which makes large-scale research difficult. The exact cause isn't always clear, although compression of the nerve root by a blood vessel is common. It also has a tendency for spontaneous remissions periods where the pain just goes away on its own for a while.
Which complicates studying treatments.
Exactly. Plus, we lack a definitive objective test to confirm the diagnosis. Treatment usually starts with anticonvulsant medications, with carbamazepine being the most consistently effective.
And if drugs don't work?
Then you move to surgical options, which are quite invasive. Microvascular decompression involves surgery to move the offending blood vessel away from the nerve. Or there are destructive procedures aimed at damaging the trigeminal nerve or its ganglion to stop the pain signals, but those carry risks of permanent numbness.
Okay, last one in this section. Headaches, specifically migraine. What's the current understanding of what causes it?
It's generally considered a neurovascular disorder, meaning both the nervous system and the blood vessels in the head are involved.
Oh, so?
Well, there are a couple of leading ideas. One points to a migraine generator deep in the brainstem that kicks off the attack cascade. Another important finding relates to the cortex, the brain's surface. People prone to migraines seem to have a fundamental difference in how their brain processes sensory information specifically. They show deficient habituation.
Deficient habituation. What does that mean?
Yeah, it means their brain doesn't tune out repetitive or constant sensory input like a non-migraine brain does. So even between attacks, their brain might be subtly hyperexcitable or overly responsive to lights, sounds, smells. This is thought to be an underlying vulnerability marker.
Interesting. Now, for treating an acute migraine attack, what's the first line for mild ones?
For mild to moderate attacks, simple analgesics can work well, but the key is dose and formulation. High doses are needed, at least 1,000 milligrams of paracetamol or aspirin, or a good dose of an NSAID.
But there's a complication with absorption, isn't there?
Yes. During a migraine attack, many people experience gastroparesis. Their stomach slows down or stops emptying properly. This means pills just sit there and don't get absorbed effectively.
So what's the solution?
Take the analgesic with an anti-nausea drug, an antiemetic like metoclopramide or domperidone. These drugs not only help the nausea but also act as prokinetics. They help get the stomach moving again, improving drug absorption and making the painkiller more likely to work.
Good tip. And finally, a really important warning about headaches. Medication overuse headache, MOH.
Yes, this is a huge, often missed problem. It's a headache caused by taking acute headache medications too often.
The cure becomes the cause.
Precisely. It can happen with triptans, opioids, Even simple combination analgesics containing caffeine or codeine, if used too frequently, typically more than 10 or 15 days per month, depending on the drug.
How does it happen?
The constant exposure to the medication actually changes the brain's pain processing systems, making it more sensitive and lowering the threshold for triggering a headache. So, as the drug wears off, a rebound headache occurs, prompting the person to take more medication, and the cycle continues.
And breaking that cycle is hard.
It requires stopping the overused medication, which often leads to a temporary worsening of headache, a withdrawal phase. It usually needs careful management, often introducing a preventive medication alongside behavioral strategies. It's a really significant clinical trap.
Okay, now we're diving into pain caused directly by damage to the nervous system itself. Let's start with peripheral neuropathies, damage to nerves outside the brain and spinal cord. Postoperative neuralgia, PHN, is a tough one.
Yeah, PHN is pain that sticks around after a case of shingles. The herpes zoster infection has cleared up. And the risk goes way up, with age affecting maybe up to a third of people over 80 who get shingles.
What's happening in the nerve to cause that lingering pain?
The shingles virus damages the sensory nerves. This can make the peripheral pain receptors, the nociceptors, become hyperactive and fire spontaneously. And this constant abnormal signaling bombarding the spinal cord leads to that crucial problem we keep mentioning: central sensitization. The central nervous system itself becomes hyperexcitable.
So you're dealing with both peripheral hyperactivity and central changes. How do you treat that?
It often requires targeting both. Topical treatments can be really helpful for calming the peripheral nerve endings, things like lidocaine patches, simple cooling, or sometimes high-concentration capsaicin patches.
Capsaicin from chili peppers, how does that work?
High concentrations basically overwhelm and then shut down those hyperactive C fiber nociceptors for a period. But the initial application can be intensely painful itself, so it often has to be done under local or regional anesthesia.
Wow. Okay, another major cause of peripheral nerve damage is diabetes, diabetic neuropathy.
Yes, a very common complication. Typically, it's a symmetrical sensory polyneuropathy, meaning it affects multiple nerves, usually starting in the feet and hands, in a stocking and glove pattern.
What are the symptoms like?
It can be a mix: numbness, tingling, pins and needles paresthesia, but often also spontaneous pain, sometimes a deep aching pain, other times sharp, shooting, lightning-like pains.
And what's the underlying damage to the nerve?
It can involve both damage to the nerve fiber itself, the axon, and damage to the myelin sheath, the insulation around the nerve. The sources suggest that often demyelination loss of that insulation is a key factor contributing to the abnormal signaling and pain.
Okay, now let's shift from peripheral nerves to the central nervous system itself, the brain and spinal cord. Central pain syndromes, CPS.
Right. CPS is defined as pain caused directly by a lesion or disease affecting the central somatosensory system, so damage within the brain or spinal cord's pathways that handle sensation.
What kind of conditions cause this?
Stroke is a common one, leading to central post-stroke pain, or CPSP. Spinal cord injury is another major cause. Multiple sclerosis, or conditions like syringomyelia, where cysts form within the spinal cord, can also cause central pain. The key is that the damage has to be within those sensory tracts.
And clinically, how does it present? Is the pain linked to other deficits, like weakness?
Not necessarily in a direct way. The defining feature is that all patients with CPS have some measurable abnormality in their somatic sensation, maybe altered response to touch, temperature, or pinprick in the affected body area. But the pain itself often exists independently of any motor problems or coordination issues they might also have from the lesion. It's the sensory system itself that's generating the pain signal inappropriately.
This brings us to a really difficult question. How well do these neuropathic pains, whether peripheral like PHN or central like CPSP, actually respond to standard painkillers like opioids?
Yeah, this is a crucial point and somewhat controversial, but the general consensus reflected in the sources is that neuropathic pain responds poorly, or at least much less reliably, than traditional nociceptive pain, like pain from inflammation or acute injury.
So just increasing the opioid dose often doesn't work well.
Often it doesn't provide adequate relief and just leads to more side effects. It strongly suggests that the underlying biological mechanisms driving neuropathic pain are fundamentally different from those driving inflammatory pain.
Which is why other classes of medication become so important, particularly antidepressants.
Exactly. Specifically, the older tricyclic antidepressants, TCAs like amitriptyline or nortriptyline, are described as the best documented drug treatment for neuropathic pain.
But they work for pain even if the person isn't depressed.
Yes, that's the critical finding. Their analgesic effect is independent of their effect on mood. In fact, the pain relief often kicks in faster at lower doses than the antidepressant effect does.
How do they work for pain?
The thinking is they modulate pain pathways in the brain and spinal cord primarily by blocking the reuptake of key neurotransmitters like norepinephrine and serotonin, essentially boosting the body's own pain-inhibiting systems. Studies on central post-stroke pain, for instance, showed significant pain reduction with amitriptyline even in patients who weren't depressed.
Fascinating. Okay, let's zoom in on one specific type of central pain. Spinal cord injury, SCI pain. This must be incredibly complex.
It is, and often involves multiple types of pain simultaneously. One very common pattern, though, is called transitional zone pain.
What's that?
It's pain felt right at or just below the level of the spinal cord lesion itself. It's often described as burning, aching, or stinging, sometimes like a tight band around the body. It seems to relate to damage to the nerve roots entering or exiting the cord at that injured segment.
And people with SCI often develop extreme sensitivity too.
Yes, allodynia, where normally non-painful touch, like clothes brushing against the skin, becomes intensely painful, is very common, especially below the level of injury. This reflects profound central sensitization has occurred in the spinal cord circuits below the damage.
Given how difficult SCI pain is, what's the typical management approach? Is it just high-dose opioids?
No, definitely not as a first-line strategy for the chronic neuropathic component. The modern approach is more stepwise, focused on trying to calm down that hypersensitive nervous system.
So what comes first?
Often, you start with those antidepressants we just discussed, especially PCAs or SNRIs, which affect norepinephrine. If those aren't enough, the next step is usually membrane-stabilizing drugs, which are often anticonvulsants like gabapentin or pregabalin.
Where do opioids fit in?
They're generally considered adjuvants, meaning additions for managing breakthrough pain or particularly bad flare-ups, rather than the mainstay of continuous treatment for the neuropathic element.
And if drugs are enough?
Then you might consider neurostimulation techniques, starting non-invasively with TED and NES, potentially moving to implanted devices like spinal cord stimulators if the pain remains intractable. It's a careful, escalating approach.
Okay, let's broaden our view now to the overall therapeutic toolkit for managing pain, especially chronic pain. Going back to pharmacology, let's talk opioids again, but specifically about how they're used long-term. Oral is preferred, right?
Yes, for chronic pain management, oral administration is generally the way to go for stability and convenience. But you absolutely have to factor in first-pass metabolism.
Can you explain that?
Sure. When you take a drug like morphine by mouth, it gets absorbed from the gut and goes straight to the liver before it gets into your main bloodstream. The liver metabolizes or breaks down a significant chunk of it on that first pass.
So less active drug actually reaches the rest of the body.
Exactly. It means oral morphine is considerably less potent, maybe only 1/2 to 1/3 as potent as the same dose given by injection, bypassing the liver initially. Dosages have to be adjusted accordingly.
Now, what happens if someone's been on an opioid for a while and it stops working as well due to tolerance, or the side effects become unbearable? Is the only option to just keep increasing the dose?
Not necessarily. A really important strategy is opioid rotation.
Switching to a different opioid. Why would that help if they're all in the same class?
It seems counterintuitive, but it often works because of something called asymmetry in cross-tolerance.
Okay, break that down. Asymmetry and cross-tolerance.
Think of it like this. When your body develops tolerance to one specific opioid, say morphine, the opioid receptors change slightly to become less responsive to that specific drug. But that change might not make them equally unresponsive to a different opioid, say fentanyl or methadone, which have slightly different chemical structures and might interact with the receptors in subtly different ways.
So the tolerance isn't perfectly transferable between drugs.
Exactly. It's asymmetrical. So you can often switch to a new opioid, start at a lower equivalent dose than you might expect based on conversion charts, and regain good pain relief with potentially fewer side effects. It helps reset the balance.
And you mentioned methadone specifically earlier. Does it have unique properties for rotation?
It does. Methadone is interesting because besides acting on the standard opioid receptors, it also blocks NMDA receptors,
Which are involved in?
nerve signal transmission, and crucially, central sensitization and neuropathic pain mechanisms. So its dual action makes it a particularly valuable option when rotating opioids, especially if there's a neuropathic component to the patient's pain.
What about managing the common side effects of long-term opioids? Do people develop tolerance to all of them?
There's a clear split. For CNS effects like sedation, maybe some initial confusion or delirium, tolerance usually does develop over time with stable dosing. People generally become less sedated.
But not for constipation.
That's the big exception. Opioid-induced constipation is almost universal. It doesn't seem to have a strong dose relationship. Even low doses can cause it, and tolerance rarely, if ever, develops. You don't get used to it.
So managing bowels is essential from the start.
Absolutely mandatory. Proactive, regular laxative use is needed for almost everyone on long-term opioids.
Okay, let's shift from pills to procedures. Regional anesthesia and nerve blocks. You mentioned earlier they sometimes provide relief way longer than the drug should last. That's still a bit of a mystery, right?
It really is one of the most fascinating areas. You see studies where a simple local anesthetic block is given for, say, a peripheral nerve injury, and the anesthetic itself should only work for maybe 4 to 12 hours.
Right.
But the patient reports significant pain relief lasting for days, sometimes even up to a week.
So it's doing more than just temporarily numbing the nerve.
It must be. The thinking is that the block isn't just stopping the signals for a few hours. It's somehow interrupting or resetting the abnormal pathological signaling patterns that have become established in the central nervous system, that central sensitization. It breaks the vicious cycle, at least temporarily.
Which is perhaps why combining agents in a block is powerful. Multimodal blocks.
Precisely. Using a cocktail of drugs, maybe a local anesthetic plus a small dose of opioid, plus an alpha-2 agonist like clonidine, often delivered via an epidural or peripheral nerve catheter, can provide more potent and potentially longer-lasting analgesia. Each drug hits a different target in the pain pathway.
And clonidine is particularly relevant for nerve pain.
Yes, the data suggests its action on alpha-2 adrenergic receptors can be specifically beneficial for neuropathic pain states when added to regional blocks.
Okay, what about simpler physical treatments?
Yes.
TNS units, transcutaneous electrical nerve stimulation. They seem popular, but what's the solid evidence?
10NS has definitely persisted. Part of its appeal is that it fits nicely with the gate control theory, the idea that stimulating large non-pain nerve fibers can close the gate in the spinal cord to incoming pain signals from smaller fibers. It makes intuitive sense.
But does it hold up in rigorous trials?
The sources are pretty blunt here. Robust scientific evidence from high-quality randomized controlled trials is still conspicuously low. Doesn't mean it never works. There's lots of anecdotal support, and it's very safe. But proving its specific efficacy convincingly has been difficult.
What about the real basics, heat and cold?
Both can definitely help alleviate pain and reduce muscle spasm. They work by directly affecting nerve conduction and blood flow. The key is when to use which.
So cold first.
Cold cryotherapy is best used early after an acute injury, like a sprain or strain. The vasoconstriction narrowing of blood vessels helps reduce bleeding into the tissues, swelling, and inflammation.
And heat later.
Heat thermotherapy is generally better for more chronic aches or later in the healing process. The vasodilation widening of blood vessels increases blood flow, which can help relax muscles and perhaps speed up the resolution of inflammation or hematomas.
Do they actually change pain perception?
Yes, both heat and cold have been shown to significantly raise the pain threshold in the treated area, but the effect is temporary, usually wearing off within about 30 minutes after you remove the heat or cold source.
Okay, finally, let's bring it all together with the psychological side. Cognitive behavioral approaches, or CBT. This connects right back to the neuromatrix idea we started with.
Absolutely. CBT for pain is essentially the clinical application of that biopsychosocial neuromatrix understanding. Its core goal is to help the patient shift away from thinking, my pain level directly equals how much tissue damage I have,
The old Stream 1 idea.
towards understanding how their thoughts, their emotions, their beliefs, and their behaviors profoundly interact with and influence their sensory experience of pain.
So how does CBT actually help someone cope better?
It teaches practical skills. Patients learn to identify unhelpful thought patterns like catastrophizing, this pain will never end, my life is ruined, and challenge them. They learn relaxation techniques, pacing strategies to avoid boom and bust cycles of activity.
And it empowers them.
Critically, yes. They're encouraged to see negative thoughts or feelings not just as awful symptoms, but as cues, signals to actively deploy one of their coping strategies. And importantly, when they make progress, they're guided to attribute that success to their own efforts and skills, not just luck or a good day. This builds self-efficacy, the belief that they can manage their condition, which is incredibly important for improving quality of life despite chronic pain. #TagOutro.
So after covering all this ground, what's the big takeaway? We've seen this huge revolution in understanding pain, recognizing the brain's absolutely central role.
Yeah, and we've developed this amazing sophisticated toolkit, multimodal drugs, nerve blocks, physical therapies, CBT.
But, and it's a big but, the sources are really clear that the mission is far from over. Too many people are still suffering.
It's a tough paradox, isn't it? We have so much more knowledge now. We understand central sensitization. We have drugs that target neuropathic mechanisms. We know the importance of psychological approaches. Yet, pain remains undertreated for many.
Where does the failure lie, according to the sources? Is it just needing more research?
Not primarily, no. The emphasis is more on a failure within our systems, educational, healthcare, other social systems, as they put it. We haven't yet managed to consistently and effectively implement the knowledge and strategies we already have across the board.
So the science has maybe outpaced the delivery system.
You could say that. The challenge now isn't just discovering new things, but ensuring that what we know actually reaches the patients who need it in a comprehensive, integrated way.
So wrapping this up, considering that fundamental shift in theory, the brain isn't just feeling pain, it's constructing it based on everything. What's the final challenge or thought we should leave listeners with?
I think it comes back to that implementation gap. If we truly accept the science that pain is this complex brain output, influenced by thoughts, emotions, context, how do we change our systems? How do we make sure that every report of pain is taken seriously, investigated thoroughly, and treated with these comprehensive, multimodal, brain-aware strategies, even when, or perhaps especially when, a simple, obvious physical cause isn't immediately apparent?
Making the implications of the neural matrix a reality in every clinic for every patient, that's the ongoing task.
Exactly. It's a challenge for all of us, healthcare professionals, educators, policymakers, and patients too.
A really important challenge. Thank you for breaking all that down. And thank you for joining us for this deep dive. We'll talk next time.